guys. Welcome. We're here back for the episode. I am so excited to be back. I have a special treat for y'all today. We have two guests on the show today. Y'all remember my trusty co-host, Maya Turner. Welcome to the show, Maya.
Hello.
And of course, our special guest for the show this week is Keisha Wilson. Hello, Keisha.
Hi.
So excited to have you girls on together, and especially you, Keisha. You know, Maya's with me pretty much every week, and we talk about various topics, but I wanted to have you on because I want to let our audience know Keisha is going to be speaking on risk adjustment, actually, at our Bone and Joint Summit in July of this year. So we wanted to kind of have her on to talk about that, but also to really talk to our audience about risk adjustment, because I get a lot of questions about it. I get a lot of people asking, because I used to be the one they all went to when they wanted to figure out what course they wanted to take to become a coder. So they would always ask me, what's hot right now? What should I do? Where should I go in my career? And for the last several years, a lot of my push has been to encourage them to go towards risk adjustment because it's such a need. It's such an area that is valuable. And we don't know what the future holds, but we know what we see as far as issues going on in the industry, data we're not getting. And I feel like if we can train people the right way to get the documentation correct, the ICD-10 codes, get those out correctly, even if we're not working in risk adjustment, if you learn what you can about it, I feel like it's super helpful. So Keisha, I'm going to let you tell our audience, what is risk adjustment in a nutshell? You don't have to go in too deep, but what is risk adjustment?
Thank you again, both of you, for having me on. I appreciate it to talk about risk adjustment. It is one of my favorite topics. I teach on it. So risk adjustment, you'll hear risk adjustment and HCC usually hand in hand, like the hierarchical condition category. So risk adjustment is the methodology that is used to pay health plans depending on the patient's conditions, disability status. They're paying like on a per capita basis, so like per member per month. And we have various models. So they look at basically risk adjustment explains what HCC does, right? We group these diagnoses into a condition category, diagnosis groupers, and then we put them all together in a hierarchical condition category, and then we assign risk adjustment factors or RAF scores that's attached to them. So it's explaining the diagnosis codes that's in this group. Then they're also taking additional stuff like the patient's age, their gender, disability status, if they have ESRD, hospice, and they assign this number. And this is telling the insurance companies like, okay, well, this is how much you're going to spend on this patient per month or even for the year. And this is how they're paid. Like CMS pays them depending on the risk score of the patient. That's my short summary. It's longer than that, though.
Oh, yes. Excellent stuff. So back in the day, I think it was like when I was first starting out in my first role in 2007 in the hospital, it was right around that time when I started to hear like whispers and kind of like these faded memories that I have of this topic. And I didn't pay much attention to it because I was a baby coder. I had just started kind of digging into coding. I was a biller before that. So I was just learning. All I had in my mind was I got to learn how to code. I know how to submit claims. I know how to get things paid to a certain extent, but I want to learn the coding part. That was my first step into it. And so I heard faint whispers. Now, Maya, when did you first hear about risk adjustment? How long have you been kind of hearing about that?
Oh, I don't want to tell my age, but I've been literally since 2008.
Yeah.
I used to literally go to the facilities and do the audits to do HEDIS, and I did risk adjustment coding and things. And we would literally go to the hospitals and abstract the codes and look at the charts, the paper charts. So we would go on these campuses and they would put us in this room and we would have all these really daunting, dusty insect on occasion boxes full of papers and documentation. And a lot of times it's actually I actually went to the area where Epic was also introduced in Janesville, Wisconsin. That's where Epic is housed, and that's kind of where the hub of everything is. So we went to a lot of their facilities that was around, and we would go into the record and abstract from there. I worked for what was then called Outcomes, which is now Change Healthcare. So yee! But yeah, it's been quite a. I
Oh
mean,
yes. Oh yes.
it's since 2008 that I've worked it, but I haven't worked it actively in some years now. But I used to be in project management. I used to be the manager for a remote healthcare company where we had like 100 remote coders doing that kind of thing. So it was a lot. It was a lot, especially when the spectrum and the course of expectations changed daily because of the deadlines that were coming up because of how um, the years would kind of go for the retrospective. You had once every 6 months, and then you wanted this much by this time and this much by this time. So it was yeah. Sure.
Yeah.
Yeah, you both, I think you both said something or a few things that, yes, around the year like 2007, 2008, a lot of people don't know that risk adjustment has been around
For a
for
long.
quite some time. Some people are only hearing about it now,
Yeah.
but certain things like like the chronic illness disability payment
Yeah.
from they were actually doing risk adjustment first, like in the 90s. And
Yeah.
then we were looking at DRG on the inpatient side, but they're like, wait a minute, we're getting paid, the outpatient side is not getting paid as much, but there's managing these patients with chronic conditions on a different level. And if you manage them in a certain way in the outpatient setting, now you're avoiding them going to the ER,
Yeah.
inpatient, where you're incurring more healthcare dollars. So they took a look at it and was like, you know what, let's create this for the outpatient setting. Let's do the risk adjustment. And so, like around 2004, I believe, and they started implementing it slowly, like 2007, and we started seeing it on the outpatient side. But if you think about it, it makes sense. If we keep our patients healthy in the outpatient side, we're going to avoid spending all these healthcare dollars when they're being admitted into the inpatient setting. So we focus a lot on diagnosis, unlike CPT. Of course, we're looking at what procedures and stuff were done, but diagnosis coding is like the biggest thing. So you can't avoid your guidelines. Like, I feel like you have to know it.
Yeah.
It's important when it
Yes.
comes to accuracy.
Yeah. And a lot of people
100%.
yeah, I mean, and what we also used to focus on a lot too is what the note was supporting, right? If it was an E&M visit, if it was a progress note, you had a lot of things that could have been addressed that they looked at labs or whatever, and it's not necessarily showing up in the assessment and plan, but it could be risk adjusted. So as risk adjuster coders, we could look at the evidence of what was being managed, but it wasn't always captured in the E&M service, and we had a lot of problems with our providers and the organization that I work for currently, where they're always looking at labs and they're never addressing it. So they had to put a best practices and some advisory things into Epic to make sure that when they addressed it, they kind of marked that they were addressing it. So it kind of helps with their level of service.
Right. And when I tell people ask me about it all the time, I try, if they don't know anything about it, I just like, I keep it simple, it's like, it's all about cost, you guys. It's all about how much is it going to cost to insure this patient, to keep them getting the services that they need, right? Because at the end of the day, the patients need the services, but the money has to come from somewhere, right?
Right.
So we kind of think of like all of our Medicare patients, let's just use this as an example. They start out with an amount of money that's set aside for them. And based on how severe their condition is, you can have diabetes, right? You can have other conditions stacked on top of that. Of course, like Keisha mentioned, you can have your demographics and your disability status that stacks up more on top of you, right? So now you become more expensive to the health plan,
right,
compared to myself, who, like, I use as an example, I'm relatively healthy. I don't have any chronic conditions. I have a traumatic injury that now made me have arthritis forever. but before that, I was relatively healthy, and even now I don't require a lot of healthcare services, medications, all kind. I don't really need anything, so I'm easy. You know, when I get to Medicare age, hopefully I'm not going to cost the healthcare system too much money. Hopefully I'll stay healthy enough, but you know, I'm like 15, 20 years away. Right. So I want to help people, understand that that's where what we're talking about. And then we have not just Medicare, we have our commercial plans, we have Medicaid. So different demographics fall into different areas, right? Where we have to assess the risk to that patient. So it may not be they're old enough for Medicare, or maybe they'll have Medicare because of disability, but maybe, just maybe, they have a chronic condition, or you have to assess how much they're going to cost you on a commercial side or on the Medicaid side. And then there's drugs, which is a whole other gamut. So Keisha, can you kind of walk us through kind of like, let's just talk about the commercial side, for instance, because they look at different things. So if you could maybe just kind of ballpark it, what are some differences between what a commercial plan might look for versus Medicare?
Okay. So we have, we have the fee-for-service Medicare, and then we also have the commercial plans, and then we have the Part C plans. So each one of them are looking at diagnosis, of course, and the conditions and the chronic conditions and the complications and any acute conditions that the patients may have.
Right.
They have a list of different diagnoses or groups or hierarchies that they look at, like neoplasms, vascular disease, diabetes, amputations. Statuses are always important when it comes to these conditions as well. As we mentioned with Medicare, they're looking at the age, because when you think about it, as Jennifer said, a younger person is not going to cost as much healthcare dollars as a elderly patient that has multiple comorbidities. If you have Medicare, Medicaid, if you have end-stage renal disease, they're looking at this type of stuff, right? And of course, now we have the commercial side, so they're also assessing medications, how much you're spending on medications, testing that you're having done, and what are you gonna cost these health plans going forward? As Jennifer mentioned, are you going to incur more costs where they are spending more, or are you saving them? And then they also created certain organizations like the ACO, the Accountable Care Organizations, that's now coming together to provide this high quality care to their patients at the right time while saving healthcare dollars. And then they earn savings. So these are all things that they're doing, to keep the patients healthy and safe, of course, but also watching how they're spending healthcare dollars and doing so more wisely. So you may have some insurance companies, like, of course, we know CMS does things a certain way, so they may be looking at specific diagnosis and criterias, and then the health plans may be looking at the same, but they may not look at all the diagnosis codes they're looking at. The risk adjustment scores may be a little different, right? From someone that has like a 0.5 versus a 2.0, and this is how they get paid. And you want to also keep in mind one thing with like Medicare, for example, if you don't report the code from January to December, they're thinking that it's resolved and it no longer exists. So you also want to keep in mind that it's important to do so. They use the annual wellness visits, or they encourage providers to document and capture it that one time. Of course, anytime a patient comes in, you want to address it so we can pick it up. But in case life happens, the annual wellness visit is the best time to do so. So we're looking at those records. Some are looking at the whole patient's chart, like an inpatient stay versus an outpatient dates of service, this one date of service, for example, in a nutshell.
Very nice. I love it. I know, but you're good. You're good. You're doing great. And, I think we had mentioned, of course, the topic for this session is orthopedics. We're going to pick on orthopedics today. So let's get right into it. Let's talk about orthopedics. That's my baby. Everyone knows that I'm obsessed with orthopedics because it's what I've been in the longest, and it's what I know. It's what I'm passionate about. And so that's why we're having you as a speaker. You're going to be our ICD-10 guru at the conference. And specifically what Keisha is going to focus on is risk adjustment. But in that session, you're going to get an ICD-10 education, I promise you, because when you focus on the documentation, when you focus on how is this provider managing this condition they have, right? You're going to help those risk adjustment coders, those that abstract that data for risk adjustment purposes, get it right.
Yeah.
So it's even if you're not in risk adjustment, your job is so important.
Yeah.
Because you're helping gather the correct data that is used to forecast and historically to look at what a patient needs, what they've needed in the past, what they're costing historically, and then of course how that's going to project in the future. So it's super important, all you ICD-10 coders, well, all coders, because most of us, right, do both procedures and ICD-10. So we have to get both right.
Right.
So I think it's just an important thing to mention. And Maya, you were mentioning earlier offline, some of the things that we see in orthopedics is our drugs, our injections. And sometimes what happens is we miss valid pieces of that not only tell the patient's story, of course, medical necessity, why do they need this drug? These are expensive drugs. A lot of them, if they're biological or if there are ones that are expensive to purchase, they have to actually either use on one patient the whole thing, and it's very expensive. It's important to get it right because you want to get paid to cover the costs that we're purchasing, and then the health plan wants to know, does this patient really need this?
Yeah,
because it's expensive for us to cover, right? And so that's a whole other gamut to that. So let's talk about that, Maya, for a minute. In orthopedics, what are some of the things that we see that can limit our ability to get paid correctly on the drug side?
I think that's a really loaded question. I think, Jennifer, you know me.
I love to load you down, right?
I think one of the bigger things is a lot of times when the providers are addressing certain issues and things come up, they don't realize that they can get an additional E&M service if there's a risk that there's assessing in addition to the joint injection or whatever that issue is, because if they think it's all bundled when it really isn't. So if the documentation is supported and they're saying, okay, let's evaluate this. Well, let me give you this drug first and let's see how it goes. Oh, you know what? I see this other knee is really, your osteoarthritis is coming up, and let me give you an injection on this. They don't realize that they could still get an E&M if it's another laterality that's associated with it, and then reporting the drug that they use for the injection. So they miss out on two opportunities to capture revenue, which is the E&M service as well as the drug. Even though traditionally the drug, in addition to for the injection, is not reimbursable at a higher rate, but it still is reimbursable and capturable, when they address the problem that's new to them. They are trying something and then they say, you know what, let me give you an injection on this knee, but we'll try the pill on the other knee. So the laterality that's associated with that, the revenue capture that's associated with both the E&M and the J code for the drug is really going to be key, because a lot of times they miss out on that. And that's money left on the table.
100%. And we're all lately, we have a lot of people asking me about orthopedics, principal care management. I've been questions about G2211, the infamous G2211, which I'll be talking about next week twice, actually. I got myself in on 2 AAPC meetings the same week, and they both picked G2211. So you'll have a double chance to hear me talk about G2211 next week. So stay tuned for more information on that. But I'm excited because I love talking about, because think about a patient who comes in. I mean, a lot of patients bypass their PCP for many things. I mean, I can't even tell you. I mean, I did recently go to my PCP because I needed a referral to get to my ENT. And I mean, not that I don't love her, but the only reason I went to 2 doctor's visits is because I had to get a referral to get there. And so, I bypass.
Tell you.
If I can bypass 2 physicians, one physician to get to where I need,
listen,
I'm gonna do it. So I'm just telling you, some patients like me will try to get to a specialist because I know that's what I need. Some patients don't know that. So yeah, they're gonna go to their PCP. So internal medicine, they really help you manage a lot of conditions, and they will send you off to the specialist that you need to be with and make sure you're going, right? So but in some cases, you bypass that. That orthopedic physician, they're the principal physician that is going to manage this condition for you. they are the one that's taking ownership and responsibility for this condition,
Yes.
right? So we want to get that right. We want to get you paid for that work you're doing. You're taking the onus, as Kim Joel Williams always says, take the onus, and you're taking that ownership of that responsibility. And so that can help you with the G2211 scenario, but it can also help you capture the medical necessity you need, all of the things, right? How are you managing this condition? How serious is it? How long have they had it? What are you doing to manage it? Is the patient taking their medication? Why not? Give us everything.
I was doing education this week, then I had to write a tip sheet on it. And one of the most interesting questions came up is, what if the patient is on high risk medications? What if the patient is on this, or what if the patient is on that? And it's typical for us to do XYZ. I said, well, you got to look at it. Are you looking at the risk? Are you looking at the complexity to manage it? So is it risk or complexity, or is it both that is making it a more complex situation if all of your patients present as complex? So you got to really kind of break down why it goes above and beyond. So that orthopedic patient who's, has pathologic fractures, and then, they have other conditions that may need to be managed because they're on that drug, and then maybe they have some issues where they're on an income limited budget, right? So they can't afford their formulary. So that was another instance where the G22 could be used, because there's complexity that's involved, not only complexity, but SDOH, which is also implied in using that G2211. So you got a lot of different scenarios where it could be applicable, and what can make it the risk in addition to the complexity.
Yeah, I
Right,
think
exactly.
you both hit great points when it comes to ortho documentation. Anytime I teach or speak about risk adjustment, you can't forget about E&Ms, because I love those too. And I
Yes.
always say documentation, right? We know it's a legal record. Once you document clearly from the chief complaint all the way down to the medical decision making, everything is going to be clear. Whether you're using a SOAP note, I hope we all know what SOAP, right? Subjective, objective, right? Assessment plan, maybe not. Or if you're using NEAT, right? I know Jennifer mentioned, right? Monitor, evaluate, assess, and treat. You're clearly documenting what's going on with the patient. So you're telling the whole story from beginning to end. And so we understand exactly what's going on. You're updating medication. Are they doing well? Did they stop? Is there adverse effect? Are they underdosing? So once you document, you're not only fulfilling, as Maya said, the evaluation and management, you're also fulfilling the HTC, capturing it to the highest level of specificity, but you're capturing other measures, the HEDIS measures, the MIPS measures. So, and then we can extract exactly what we need, but oftentimes we love our physicians. We know they're overwhelmed. They can keep things in their head. And that's why we can't run away from that term. If it's not documented, it's not done, because we look in the record and it's often lacking. And that's one of the risks when it comes to risk adjustment, right? Risk adjustment. You like how that went. And then also we have the OIG, right? Remember, they were looking at the work. There was something they put out in December where they was mentioning like a history of condition was being documented when it was a current condition.
Oh my
And
God.
that was something, with hematology and oncology, that's always something that we run up against.
Yeah.
And so, these are all important things that we need to understand so we can assess and report these conditions accurately. And so ortho, as you mentioned, is one with the conditions that they see. Sometimes they forget that patients use them as the primary care. And I did front desk like 20 years ago, so I saw that they would bypass internal and use a specialist. And it's like, when's the last time you spoke to your PCP? They was like, who? Your primary care physician. When did you last see them? And they're not communicating. So that's the thing with risk adjustment. We're using the risk scores. We're looking at the diagnosis for all the physicians. So we're looking at physicians, NPs, PAs. We can extract data from all of these notes and then report it accurately. So it's teaching all these physicians to know that your documentation matters, and not just because you're a specialist that you're not going to capture everything and document it properly, because they're using that data. And that's how we know something's missed. Like with the perspective logic, they're looking at algorithms and they're like, okay, we see the pharmacy, right? Prescription, like they're on albuterol, for example, but we don't see any diagnosis of asthma and COPD. So now we have to go back and look in the note and we're
Yeah.
like, oh, this was missed,
Yeah.
so stuff like
Exactly.
that.
Yeah.
Well, that's great stuff. I'm so excited to hear more about your session at the upcoming conference. So the Bone and Joint Summit is going to be on July 13th and 14th. We're going to have 16 CEUs for you. We're covering the kitchen sink of topics. So we just got Don Self to come on with Alicia Stott. We're going to do a compliance panel. So I'm really excited about that. Of course, the fabulous Jessica Burke and I are going to hit hard a lot of the sessions. We kind of tag team most of the surgical topics. And I have Tanya Silva, who's usually our podiatry expert, but she is actually coming on to talk about E&M. She loves E&M. And so I told her this year, yes, let's talk about it. I will also be speaking on G2211 for orthopedics and podiatry, because there's a lot of questions about those two, and I wanted to answer those for people. So there'll be a topic on that. And so I want to thank you all. I know this was one of those episodes where we wanted to kind of give you an insight into an area you might be interested in. So if you're interested in risk adjustment, please contact Keisha Wilson. She is, as we know, an expert, and she can help you figure out if that's the road for you. And thank you once again, our lovely co-host, Maya Turner, for always joining in and giving her insights. I hope you guys have a wonderful, wonderful afternoon and great weekend. We will see you in July, and we'll see you next week for our next episode. Thank you, guys.
Thank you.